completely revolutionized the treatment of this disease. It used to be very disappointing what we could do. Now it's very gratifying what we can do. So we're going to talk about this, and this gives us an opportunity to do so, which we can't do with each and every one of you when you're being seen. So this gives me a half hour to bring you up to date on those treatments. And I really appreciate that opportunity. Now this slide shows progression of different studies that we've done in macular degeneration. And when I say we've done them. As I'll show you, we've been in almost all of the studies that have led to these advancements, including the macular photocoagulation studies that went on for 15 years at the beginning that related to laser therapy for the abnormal vessels that we see in wet macular degeneration. You all heard about wet and dry macular degeneration, wet having abnormal blood vessels that grow near the center of the macula, the center of vision, and leak fluid and bleed. They have the potential to bleed, and certainly they leak fluid, and that's what destroys vision very quickly. And we've made huge progress in managing wet macular degeneration. We've also made big-time progress in dry macular degeneration, but we've got a long way to go yet. But that doesn't get as bad nearly as fast, so it's a little bit less of a problem that way. I'll be talking about geographic atrophy, the most advanced dry macular degeneration, a little bit in this talk. Actually, Kim was the coordinator and is the coordinator for the ARID study, the Age-Related Eye Disease Study, the big National Institute of Health-sponsored study that proved the benefits of vitamins, certain vitamins and minerals that we won't review. We've reviewed it here before, but you are probably, most of the patients with macular degeneration here are on these vitamins, and Kim is our coordinator for the current ongoing ARIDS 2 study that's looking at improving on the original formulation. And we were in all of these studies. That the next era after photocoagulation, cauterizing the abnormal blood vessels, was the era of photodynamic therapy, PDT. And that was, we were very involved, and actually Kim again was the coordinator in most of our PDT studies. And we have a whole cadre of coordinators, but we have some superb nurses, and I think the finest clinical trial team of nurses and coordinators in the whole country. But Kim she did most of the photodynamic therapy studies as well. And that was a whole era where we could treat the center of vision, the center of the macula, if the vessels went under the center, with a low dose cold laser combined with a photodynamic drug, and we found it was a very major step forward at that time. However, that's been supplanted now by the pharmacologic era. So what we're doing now, all these other studies, relate to pharmacology or drugs that we use to treat the macular degeneration. And those have proven to be much more effective and got better results than the photodynamic therapy and the laser therapy, although those things are still used to some extent as an adjunct to the therapy. So we'll be talking mostly about the pharmacotherapy today, because that's where we are today. And that has the benefit of not only halting progression of the disease as the other modalities did, but actually improving vision in many of the cases. Now, these are just a list that I'm not going to read of the studies that Retina Associates of Cleveland has been involved in. You'll notice on the bottom 15 years in the macular photocoagulation studies. And this is still another list of still more studies that we were investigators in, and I had the privilege to be a principal investigator in most of these studies. So these are the studies that led to the advances that I'm talking about. And this graph, which you can't see, but you can see that the blue, some of you can see that the blue lines on the bottom, mostly blue and green on this side, it shows dramatic difference between the patients that got these drugs injected into the eye. These were all Lucentis studies, which was sort of the gold standard drug that many people are getting for this. And there was just a dramatic treatment effect that you can see on these graphs. It was so much better than the natural history of the disease. So that put us in the new pharmacologic era, Lucentis. But then Lucentis, they were charging and still are charging about $2,000 a dose, so it's very expensive. So there was, fortunately Medicare does pay for it, if you're fortunate to be on Medicare, but because of that, people look for a way to do it less expensively. And many of you have heard about Avastin, or many of you have gotten Avastin. And Avastin is actually the drug that Lucentis came from. So both are made by this company, Genentech, big pharmaceutical company. Avastin has a certain formulation, and it was made for colon cancer and approved for colon cancer. And when a drug is approved for one indication in medicine, you can use it off-label, so to speak, in another indication. That's legal. If it's not approved by the FDA for anything, then you can't use it or you go to jail. But if it's approved, you can use it off-label. So colleagues of mine, one of my good friends, really, Phil Rosenfeld in Miami, spearheaded the main study that showed that Avastin worked very well, and it was much cheaper because we could take the systemic dose that you inject in the vein and cut it into many doses, at least 20 doses, maybe even more, and that would be enough to put in the eye of many people. So while that's over $2,000 a dose too, by dividing it up that way, we were able to develop a drug that's much cheaper for people that didn't, when needed. And it turns out that there was and is still a lot of controversy about whether Avastin was as good as Lucentis. And that led to the CAT study, Comparison of Age-Related Macular Degeneration Treatment Trials, which compared those two drugs head-on. And we wanted to know if the we'll get to combination treatments later, but we wanted to know if treating with Avastin was as useful as treating with Lucentis, and if we really needed to treat once a month. The great thing, these drugs work great. The problem with it is they only work for about a month or 6 weeks at the beginning, and we have to keep re-injecting it, as many of you have learned. So we wanted to find out if you really had to give it once a month, as it is on the labels, or can you give it as needed, or start to stretch out the treatments, which many of us try to do. So that was the study, the CAT study, and it compared these two drugs, Lucentis and Avastin. And we found at 1 year these findings here, which you can look at, but I'll tell you that we just had, I was in Chicago Sunday before last, where the principals and investigators of the CAT study met to discuss the 2-year results, and then the paper, the formal publication of that came out this past week, so this is current. That's why I'm focusing on this particular topic. The paper was just published this week, and then I just came back at midnight on this Wednesday from the Association for Research in Vision and Ophthalmology meeting, where the first formal presentation of these results was made. And we had a huge audience because everyone was interested in these results. The 2-year results. This is the 1-year result, and basically it shows that if you add it all up, the summary is that they are equivalent, the two drugs. There are subtle differences that we talk about a little bit, but the differences aren't nearly as important as the fact that statistically, and if you really dice it out, the two drugs were essentially equivalent, okay? I'll talk a little about some of the differences. You can see that those graphs are pretty close. You can see across the top that the percentage of people that got the two different drugs and that used them, what we call, use them monthly versus use them PRN, is almost the same on the top bar. And on the bottom, the percentage that got 20/40 or better vision is also almost the same. It's a little higher over here on the Lucentis, on the monthly. The monthly was a little better than the PRN arm that it's called, but they were really pretty close. Now the PRN arm meant we only treated them if there was some fluid. And I'll show later an example of what I meant by fluid. It could be the most minute amount of fluid and we treated them. So they were still being pretty aggressively treated even in the PRN arm, the patients, because it took just the slightest amount of fluid. This relates to the thickness of the retina, and there was a little more disparity there. The one on the bottom, the blue line, is Lucentis treated monthly. That made the retina as thin as thinner than the others, as opposed to swollen with a lot of fluid. So thin is generally better, just like some of the women usually think. But the fact is that that isn't infallible, as I'll show you later. So the questions at the end of 1 year study in the major CAT study: would Lucentis and Avastin remain equivalent for visual acuity in year 2? And would wider visual acuity differences emerge between monthly and PRN dosing in year 2? Would the fluid differences between treatment groups that we noted in the first year, again, they were subtle, but would they, but they didn't impact on the vision. And because the vision was pretty much the same, would they impact on the vision at the end of 2 years? Would switching from PRN to PRN dosing from monthly dosing with the same drug, would that still allow us to maintain the same visual result? And would important safety differences emerge? Those were the big questions we had to answer in the second year. And the second 2 year results, again, just came out in the past week. And we found that the objectives I've already told you was to find out who could basically do well maintaining the same regime. And one of the big points was if you switched a patient from monthly to PRN in the second year, would that be a problem, or would it still be okay? We had over 1,100 patients who continued in the second year. And the results show that still this was pretty close between the different treatment groups. The mean change in visual acuity for patients that were on the same regimen for 2 years is shown here, and the regimen on the top that got the best result, if you will, is Lucentis monthly through both years. And you can see that the Avastin is just a little behind it. And the others, the PRN dosing was a little behind that, but they weren't big differences. And these were the ones that stayed on the same regime for 2 years. There was, and you can see here, they're almost virtually identical with regard to how many lost 15 letters of vision or 3 lines of vision. Both at 1 year and 2 years, the results across all 4 groups are almost the same. And the change from baseline was almost the same in all these categories. Now this is showing 6 groups, and there's a 6 groups because half of the patients that got treatment every month in the second year were switched to PRN treatment. And that made 2 more groups. And you can still see that there wasn't much difference across all of these groups. The anatomical results are less important but this shows that there is a difference. Lucentis treated monthly had the driest eyes, if you will. But this shows that, and even the best sighted of you will have trouble seeing this, because we had trouble. We had to study it under magnification, showing you the minimal amount of fluid that prompted another treatment if they were even in the PRN group. That's why it was so close, because we really treated pretty aggressively. But if it was absolutely dry, we didn't treat the PRN group. Now this is an important slide. I'm not going to emphasize it too much right now, but this concept of geographic atrophy is very important. And you can see that while Lucentis had the most dry eyes, and they had the thinnest eyes, it had more geographic atrophy. So the dry form of the disease, if you will, started to take effect. And that's what causes some visual loss down the road. So there's a balancing act here. It did dry things up the most. Here, for sure, you're going to have trouble seeing, but the arrow on top shows you abnormal blood vessels that are leaking in wet macular degeneration. And then on the bottom, the patient had been treated for 2 years, and the abnormal vessels dried up completely, but you see 2 little patches of what's called geographic atrophy. Those 2 aren't bothering the vision much right now, but they're right near the center of vision, and if they invade the center, they will bother central vision quite a bit. So this shows the percentage with no leakage. It's pretty close, but Lucentis is still the best. And the area, now the mean number of injections for 2 years on the people with the same regime was 22 and 23 in the monthly groups and 13 and 14 in the PRN group. So there was a difference. All right, there was a difference in the PRN groups in 2 years. And the effect of switching was a key question, and we're going to address that question. And one of the things that emerges that is this concept of geographic atrophy. This is a patient of mine that came in with geographic atrophy, not after treatment, had the dry form of the disease, but very advanced dry form. You can see a big area here where it's lighter in color. That's the area of geographic atrophy. The darker area around it is the normal looking area. And you can see the black area on the other picture to the right is the geographic atrophy. And that's very advanced geographic atrophy and dry macular degeneration. Well, little patches that I showed you before can occur after treating for a few years. Of course, it's part of the natural history of the disease, but it does seem to occur with monthly treatments, so we have to watch that. Now, the mean change in vision, it was almost the same, I mentioned, after 52 weeks, and the thickness isn't so important. And the 15-letter change in vision was the same across all 4 groups, both with regard to the number that lost 3 or more lines of vision or 15 or more letters of vision, and the number that gained 3 or more lines, with again Lucentis being a little better. But you see here that the blue column, the Lucentis, had the most geographic atrophy if you gave it monthly. So that's the problem, and we'll just that we're balancing. And this is the 6 groups. You can see they're pretty much the same, both in terms of good vision and which is on the bottom, 20/40 or better vision. They're pretty much the same across all the groups. Now, there are adverse effects of these treatments, as there are for any treatment, but they were exceedingly rare. So endophthalmitis, which is the one we fear the most, that's an infection in the eye which can be devastating. It occurred in only 11 eyes after 18,500 injections. So it's 0.06%. So it's not very common. And even then, and by the way, one problem is it occurred in the people, in 10 of the 11 cases were monthly treatments, and the 11th case that wasn't monthly got almost monthly, got a lot of injections, received 22 injections in 2 years. So they were all essentially the monthly people. Because you're getting more injections, there's a higher risk of getting an infection. And a small percentage of people get some elevated intraocular pressure. Now, I've shown you all kinds of things that were much the same across the treatment groups, but the big difference is right here, is the cost. So the cost of Lucentis monthly is astronomical compared to the cost of Avastin, which is in the red, and to the cost of Lucentis PRN. And that's a remaining issue. So to summarize, Lucentis and Avastin were equivalent for visual acuity at all points in time over 2 years. Statistically equivalent. PRN treatment resulted in less gain in vision at 2 years, but vision for all groups was similar at the end of 2 years. PRN dosing resulted in a mean of 10 fewer injections over 2 years. That's quite significant. The Avastin patients received a mean of 1.5 more injections than the Lucentis patients. More eyes were completely dry on OCT with monthly dosing, with the highest rate in eyes receiving Lucentis monthly. That's what made it the most dry. But more eyes developed geographic atrophy with monthly dosing, and with the highest rate in those that received monthly Lucentis. So we have to balance those two things, and depending on the individual patient. PRN groups had more leakage on fluorescein and more lesion growth in monthly groups, and switching to PRN, and this was the biggest disappointment that we got last week when we came out with these results. Switching to PRN after 1 year of monthly dosing resulted, it was similar, but if you switch to PRN in the second year of a person that was getting monthly dosing, you end up where the PRN people were on day one, people that got PRN from day one, which wasn't quite as good as the monthly dosing group in terms of vision and in terms of thickness of the retina. Avastin treated patients had so we can't give, we were hoping that in the second year we could take it down from 9 treatments, let's say a year, to 3 or 4 maybe in a year. But it doesn't look like we can do that safely. Avastin treated patients had higher rates of systemic adverse events, but most of those were not related to the drug. The reason for this remains unclear, and it really didn't make a lot of sense, some of the data. Now, I have to tell you about another drug. CAT study just came out with 2-year results, so I emphasize that. But EYLEA is a new drug based on these 2 studies that is very effective. It's not more effective than Lucentis, but it is equally effective, and it's better in a certain way. It appears that you can use it less often after you get started. So the label says use it once a month, 3 times, and then you go to every other month. Now we don't know. It just got approved recently, and we don't know what the long-term. We don't have 2-year results, so we don't know it as well. But it definitely is effective, and it appears it will let us stretch out the treatments a little more, which is a good thing, which means giving less treatments, a little less risk of infection, and so on. And less trips to the office, perhaps. The problem with all this is even if you're giving less treatment, you still have to come and make sure you're not getting into trouble. So it's very tough to get away from frequent exams and get away with it. So that drug is promising. I've used it effectively in patients that didn't respond well to Lucentis, and it's something that's certainly in our armamentarium now. Now, upcoming studies I'll just quickly mention. This one I'm excited about. I'm on the scientific advisory board. It's an eye drop. Now, this is for wet macular degeneration, but we also have studied eye drops for dry macular degeneration. I've been a principal investigator in 6 different studies now on dry that we'll talk about for geographic atrophy. This is for me if this eye drop, we haven't even started the study, but we're starting it shortly. If this eye drop helps even 15% or 20%, it doesn't have to be like Lucentis. It'll be an adjunct to it. If it means we can give 5 less injections a year because we give this eye drop, it'll be a big, big deal. So I'm very excited about it. It looks pretty promising. And this is a Novartis infusion where theoretically we'll be giving intravenous. It may take the number of treatment sessions way down. But these are all hypothetical. We haven't started these studies yet. These are studies we will be doing. And the other big thing is this idea of combination treatments of, say, Lucentis or this Eylea with other drugs. And we have some very promising drugs on the horizon, but they're not approved yet. I'm on the scientific advisory board of this one, too. It's called Opthotech. This drug looks very promising in terms of minimizing the number of injections when used in combination with Lucentis. And the way it works is the cells, certain cells on these vessels are stripped away by this other drug, this anti-parasite drug, and then when you give Lucentis, it really closes down the vessels and gets rid of them. It makes them shrivel up, disappear. Lucentis, as we give it now alone, does not make them disappear. It just makes them stop leaking. And that's why you have to give another injection in a month or 6 weeks or whatever it may be. So to summarize and conclude, the likelihood of, very important is your expectations of this treatment. And the likelihood of moderate visual improvement with treatment is about 1/3 of patients can improve their vision, not just stabilize it. Without treatment, it's rare to get improved vision. The risk of moderate or severe vision loss with treatment is rare now, rare. Without treatment, it's common. So the serious injection-related risks are rare. So all in all, these treatments are fantastic. And the need for multiple treatments is a problem, and the cost is a problem. Now, further research will maximize our options in treating macular degeneration and the devastating vision loss it creates. However, we've already made dramatic progress, and now we can improve vision in 1/3 of patients, and we can maintain vision in way over 90% of patients that come in. The key is for the patients to come in early enough that if the vision's not bad or it's still good and just starting to get a little funny, we can keep it that way in way over 90% of patients. But if they come in with very bad vision already, we may improve it some, but it's not going to end up nearly as good. That is the key.